Um, and you can begin to work on your list on that particular list. You may want to put some space, maybe a couple of spaces, between each drug that you're listing in there, just to make it as far as readability. You don't want everything all jammed up, and just really take your time with it, make it nice, pretty, put colors on it, or whatever you need to do. I do a lot of that, a lot of highlighting and making stuff different colors and whatnot to hopefully help jar my memory and everything. But we all have our little quirks, I guess.
Do we have to turn it in, or can we put it on index cards?
No, it's not. It's not anything to turn in. It's just something I want you all to build, kind of like a database, and I want you to take it to, to the next course that you take until the end. It's just something that you'll be able to refer to while you're in the program. Pharmacology is a really big deal, and we need to make sure as instructors that we're giving you enough pharmacology. So that's really important. Because honestly, as I always mention to you, that's what your job is most of the time anyway. I mean, you do a whole lot of other things too, but medications is a big deal, I promise you. And it kills a lot of people too. So if you all don't understand these different things about the medications, that's what could actually kill your patient. For example, you may look at a patient who's, you're giving them an anticoagulant, and then you look at this patient's diet, and the patient has a lot of green leafy vegetables on it. So in other words, the vitamin, green leafy vegetables actually have vitamin K in it. And so you don't want one to cancel out the other because it defeats the purpose. But if you know these things, and these are things that would be in your nursing responsibilities. So you have to know these things in order to, of course, notify your healthcare provider to let them know that, hey, the patient is on Coumadin, but they have this diet that is high in vitamin K, such as green leafy vegetables. So say, for example, if you're looking at a patient's diet and you see, as I mentioned, green leafy vegetables such as kale, spinach, turnip greens, collards, Swiss chard, whatever that is, I'm not a cook, mustard greens, parsley, romaine, and green leaf lettuce. As far as vegetables such as Brussels sprouts, broccoli, cauliflower, cabbage, and also fish, liver, meat, eggs, cereal, contain smaller amounts, so it's not that big of a deal. But when you can recognize these type of foods and how they counteract the medication, the Coumadin that you're giving your patient, then you could just save that patient. Because if the patient, let's say, if they have a mechanical heart valve, they have to be hypercoagulated. So their INR has to be between 3 and 4. And so if you're trying to keep them anticoagulated, but yet this patient is eating all these foods with a lot of vitamin K in it. There's going to be a problem. And so it's up to you to be able to recognize that. But the only way you're going to know these things is by understanding these drugs. So very, very important. We're missing 2 people, I think. So let's see, Miss Lynch is here, Miss Cameron is here, Miss Emmerich, Miss Hollis. That's Miss Jones, Miss Ara, that's Miss Chantel Williams. Oh, I guess we're just missing Mr. Wolf. 8, 7. All right, yeah, so we're still missing Mr. Wolf. Maybe he's overslept, or maybe he's overslept. All right. So listen, one of the things I want to do before we get started, allow you guys to get started this morning, is I want to show you all this video that talks about the clotting cascade. I always think it's important to give you a visual first, and that way when we start talking about it, then you can understand where I'm going. But this is dealing with the clotting cascade. Yeah, just to kind of give you guys an idea, when we're talking about the clotting cascade, there's like 3 sequential steps that occurs before actual clotting is complete. And let me just say that, and you probably already read this, don't know if you really understood it or not, but the clotting cascade itself has several sequential steps to it. There may be like 10 steps to it, which you don't really have to know per se, but the clotting cascade cannot take place until the platelets do its job. So the platelets do its job, and it is what activates the clotting cascade. Your platelets and its functions and what have you is not the clotting cascade itself, but it is what initiates the clotting cascade. But once the platelets do its job, they plug up that area where a patient is bleeding. Then the clotting cascade will begin, which goes through several steps until finally the 3rd step is when the fibrin clot, which is the actual clot, is actually produced. Now, what I want you to keep in mind while we talk about this is, all right, just picture it like this. Let's say with the clotting cascade, you have 7 steps before we get to the final clot itself. When you want to give a medication to interrupt one of those steps, it will in effect interrupt that clotting process or that clotting cascade. So it will lead to no clotting. And sometimes we have to do that. We want to slow down clotting, again, because your patient may have atrial fibrillation, they may have, atrial fibrillation, they may have maybe a stroke, they may have a heart valve, whatever reason, a DVT or something like that. So you don't want the clotting cascade in this sense with those conditions to operate normally. So at some point, you'll interrupt that process. And so when you're reading about some of your different medications, it will tell you what step in that process is being interrupted. And those are the things that they typically have you, or they want you to know, or to be able to know, and to be able to answer correctly on your exams. You may have a drug that works directly against the thrombin. So, like for example, prothrombin usually leads to thrombin. But all right, so let's say if you have 5 steps. There's an enzyme in step 1 that has to be activated in order for step 2 to take place. And then in order for step 3 to take place, there's an enzyme in step 2 that has to be activated in order for step 3 to take place, and so forth and so on down the line. And so if you can interrupt one of those steps, then it doesn't occur. So let me go ahead and play this for you all first, so as to give you an idea, and then we can kind of go through what I have for you, and another explanation for you. Let's see here. Hopefully you all will be able to hear this.
In this tutorial, we're going to discuss the coagulation cascade. This is a sequence of interactions that cause fibrin deposition at the location of tissue injury. There are 2 pathways, the intrinsic and extrinsic.
You all may be able to hear this better if you have headphones on, but I don't know, your volume may be a whole lot better than mine. But just look at the picture or this drawing and how he shows you how, all these sequential steps.
Pathway. We'll look at the intrinsic pathway first. The intrinsic pathway is less important for initiating coagulation than the extrinsic pathway. However, the intrinsic pathway is very important for the amplification of the cascade. So let's look at what's involved. These pathways consist of a number of proteins called factors activating one another. These are usually denoted by Roman numerals. And the first factor of the intrinsic pathway is factor 12. The intrinsic pathway is also known as the contact pathway. This is because factor 12 can be converted to its active form, factor 12A, when it comes in contact with negatively charged surfaces. Most commonly, this surface is glass within a pathology lab. So as you can see, the active versions of these factors are denoted by the letter A. In this case, the active form of factor 12 is factor 12A. Now, factor 12A causes the conversion of factor 11 to factor 11A. Factor 11A then in turn converts factor 9 into factor 9A. Factor 9A then converts factor 10 into factor 10A. But it does this with the help of factor 8A, which has been created from factor 8. Factor 10A can then convert prothrombin to thrombin, and it does this with the help of factor 5A, which of course has been produced from factor 5. Thrombin then converts fibrinogen to fibrin. Fibrin forms a mesh at the injury site to help produce the blood clot. Now let's look at the extrinsic pathway. This pathway is much simpler, and it is the pathway which is most important for initializing the coagulation cascade. It begins when a protein called tissue factor is released from damaged tissue. Factor 7 is converted to factor 7A, and then tissue factor and factor 7A combine to convert factor 10 to 10A. The pathway then continues on like the intrinsic pathway until fibrin is produced. One last thing we need to consider is the positive feedback effect thrombin has on the cascade. Thrombin has a role in accelerating the factor 8A and factor 5A. In this way, the cascade is amplified to produce the necessary fibrin in a short amount of time. And that's an overview of the coagulation cascade. In the next hemostasis tutorial, we'll look at the drugs that can modify the formation of blood clots and thrombi. If you've enjoyed this tutorial, please help us produce more.
All right, so I don't want you guys to be afraid. You don't have to know all those steps, you know. But I think what is important about that particular video is that it does give you that visual in terms of how it goes from one step to another, because the ultimate goal is that it leads to a fibrin clot. So you just need to know that it is a multi-step process that takes place. This is that cascade that I was telling you about. You know, cascade, one thing going on to another. And so I meant to look at, probably not good to look at that particular one. I'll look at your book and see what it says. So without too much anxiety, just kind of keep in your head only that, oh, there it is. Good morning, Mr. Wolf.
Good morning, my alarm.
All right. It's probably kind of some of my fault too, because for some reason, I didn't have you and Miss Williams on my invite. Mr. Wolf.
Sir.
I hate to put you on the spot. And I'm not telling your business, but can you give us some brief examples, some ideas as to what you did to prepare for or for your first exam, if you don't mind?
I just downloaded the PowerPoints and studied those and used the book and just went through and highlighted everything I thought was what you put on the PowerPoints and what was in the book. I just used those and made my own notes and just studied them. The Tuesday was a day of study. That was all it was. Like when I woke up at 7:30, I got up that morning, made my coffee, and from 7 to about 5, I studied. I'd study for an hour, take a 20-minute break. Study for an hour, take a 20-minute break. So,
all right.
I mean, that's
So you say you looked at the PowerPoints and compared that to the book,
correct.
and then made notes from that.
Yes, I made my own notes from it because it was just one of those things that it helped me. That's how I learn. I'll take two things and make my own thing out of it.
Right. Did you do much? Did you sit down at some point and read at all?
Well, yeah, I was reading the book.
Yeah, I kind of thought so, but I mean, like you didn't just sit there at some point even before that and just kind of just go through the reading. You probably don't like to do that, I would imagine.
Well, things like I read it when I can, but with this, I mean, like there is hardly any time, besides between school. I mean, this is like a 40-hour week. It's over in a 40-hour week, depending on the week. I have nothing but respect for people who work and do this because, like, after I'm done with like clinicals of this, like I'm fried. Like I have to have a day to unwind. I just can't do school anymore. So Yeah, like Tuesday, it was just one of those things. Tuesday, I just went ahead and just studied my butt off, and yeah, I just got lucky.
I don't know if it's luck, but something must have got in your head.
Yeah.
All right, I appreciate that. So hopefully you all, that's Mr. Wolf's method, and so hopefully some of you can take some of that and use it as well. I typically do that with students, especially if they do very well on the HESI. I like to know what they do and share it with the class, because sometimes the class, they don't really communicate a whole lot. And you're looking at this person over here and they're hitting these really high marks. And you're thinking, well, how in the world is he or she doing that? And nobody would share anything. I knew this one young lady, she was studying to be an attorney. I think she's a prosecutor now. And she would do things like, because she was, that's a very competitive program. So she would tell these students, hey, let's get together for a study group, but let's meet all the way across town. She had no intention in meeting these people across town, but she did that because she figured while they're trying to race across town so they can meet up to study, she's at home and she's studying, so she's getting a jump on them. And so once they waste their time and she got all her studying in, then she could beat them out on the exam. So they did things like that. Back then I thought it was kind of funny, but at the same token, it would just be really nice if people would, kind of help each other out, throw some advice out there. But anyway, all right. So Mr. Wolf, as I was explaining to the class, one of the things we're doing right now is I wanted to go over quickly the coagulation cascade, or the clotting cascade. I did just show them a video. It was under 5 minutes, actually a little over 4 minutes, because I wanted them to see the steps. There's three sequential steps to ultimately clotting, or that will occur before the clot is actually formed. And so this was a nice video. Actually, not so much as that Mr. Wolf came in a little late, but let's go ahead and take a look at this again. It's a short video, but kind of get you to look at it again, just to get an idea. Because the clotting cascade is a multi-step process. It's not just something that just, boom, it just happens, but there are certain steps that must occur. And it is these steps that must be interrupted in order to halt the clotting, that clotting process. So let me go ahead and do this again, and then we'll talk about it further.
All right. We're going to discuss the coagulation cascade. This is a sequence of interactions between proteins to cause fibrin deposition at the location of tissue injury. There are two pathways, the intrinsic and extrinsic pathway. We'll look at the intrinsic pathway first. The intrinsic pathway is less important for initiating coagulation than the extrinsic pathway. However, the intrinsic pathway is very important for the amplification of the cascade. So let's look at what's involved. These pathways consist of a number of proteins called factors activating one another. These are usually denoted by Roman numerals. And the first factor of the intrinsic pathway is factor 12. The intrinsic pathway is also known as the contact pathway. This is because factor 12 can be converted to its active form, factor 12a when it comes in contact with negatively charged surfaces. Most commonly, this surface is glass within a pathology lab. So as you can see, the active versions of these factors are denoted by the letter A. In this case, the active form of factor 12 is factor 12A. Now, factor 12A is factor 11 to factor 11A. Factor 11A then in turn converts factor 9 into factor 9A. Factor 9A then converts factor 10 into factor 10A. But it does this with the help of factor 8A, which has been created from factor 8. Factor 10A can then convert prothrombin to thrombin, and it does this with the help of factor 5A, which of course has been produced from factor 5. Thrombin then converts fibrinogen to fibrin. Fibrin forms a mesh at the injury site to help produce the blood clot. Now let's look at the extrinsic pathway. This pathway is much simpler, and it is the pathway which is most important for initializing the coagulation cascade. It begins when a protein called tissue factor is released from damaged tissue. Factor 7 is converted to factor 7A, and then tissue factor and factor 7A combine to convert factor 10 to 10A. The pathway then continues on like the intrinsic pathway until fibrin is produced. One last thing we need to consider is the positive feedback effect thrombin has on the cascade. Thrombin has a role in accelerating the production of factor 11A, factor 8A, and factor 5A. In this way, the cascade is amplified to produce the necessary fibrin in a short amount of time. And that's an overview of the coagulation cascade. In the next hemostasis tutorial, we'll look at the drugs that can modify the formation of blood clots and thrombi. If you've enjoyed this tutorial, please help us produce more by making a donation.
All right, so as I explained to the class, no need to worry about trying to memorize all those steps. The important reason why I want you to see that video is so that you know that in order to prevent coagulation, then you have to interrupt one of those steps. And this is what some of your drugs do, like your Coumadin, your heparins, your Xareltos, and things like that.
Dr. Weaver.
Yes, sir.
Would aspirin be a blood thinner that or to help people that have had heart attacks? But
I'm sorry, say that again.
Aspirin, would that be considered a blood thinner as well?
That actually works on your platelets.
Okay.
And one thing I'll go over with you all, you will learn that platelets actually start off this whole process. Without your platelets, the clotting cascade cannot begin. So your aspirin actually does something a little different, just like your Plavix. Plavix also works on your platelets instead of the clotting cascade itself. Oh, Miss Cameron got kicked out. So anyway, so when you're thinking about, I'm going to go through this, of course, but when you're thinking about the aspirin, Plavix, those types of medications, they're more antiplatelet type of drugs. And so, for example, your platelets are usually within your vascular system. They're just running around in the vascular system individually. But when they're activated, they become sticky and they clump together. All right. They clump together and they seal off wherever the injury is. But it is that platelet that actually will begin eventually the clotting cascade. So entirely different mechanism of action, if you will. All right, so let me kind of go through this with you all. And you all would be able to read this on your own at some point again, but I just wanted to kind of go through it. This is actually on the slide entitled Hematological System. There's a voiceover and there's just the PowerPoint presentation that you can look at the notes on, and it's on slide number 5. It talks about the not homeostasis, but hemostasis, just dealing with the blood, hemostasis and blood clotting. It talks about this multi-stepped process of controlled clotting. And that video that you guys just saw, that's what leads to eventually clotting. And this narrator, he didn't talk about don't think he did, talked about the platelets, but we'll talk about that because that's what actually starts the process. Without the platelets, then you have no clotting cascade. This slide also talks about platelet aggregation. It talks about blood clotting. It talks about that intrinsic factor versus the extrinsic factors. And then lastly, it talks about the fibrin clot formation. So again, hemostasis is a multi-step process of controlling blood clotting, of controlled blood clotting. All right. So again, this is not something that happens randomly, but it is a controlled blood clotting process. So it does result in localized blood clotting. Well, this localized blood clotting occurs when you have damage to your blood vessels. So let's say if maybe you were cut or something, you sustained an injury. This is what causes localized clotting. Localized meaning at that particular site, not the systemic kind of coagulation that occurs with sepsis. But this is more localized. And so this is important. This localized blood clotting is important because it essentially and simply just stops you from bleeding to death. And so that's why you have this localized blood clotting. When blood, although blood is perfusing throughout the circulatory system, at that particular site is where you will have that localized blood clotting to stop you from bleeding if you're injured for whatever reason. All right. Now, something that is very important for you to know, we always talk about homeostasis. This is about hemostasis, our blood system and blood clotting. But when we talk about homeostasis in this regard, you have your blood clotting actions and you have your anti-blood clotting actions. There is a balance. There is a balance between blood clotting actions along as well as the anti-clotting mechanism or action. And so this is done because you do not want too much clotting. And yet you want clotting only when it is appropriate. So when the body needs the clotting mechanism to kick in, yes, it does kick in, but then something has to occur to stop the clotting at some point. You don't want a system that just goes, that it's just out of control, in other words. So you have that mechanism in place to prevent it from just doing what it wants to do, basically. So you have the clotting actions, and then you also have the anti-clotting actions. And just think about homeostasis. You don't want too much clotting, so you have a mechanism in place to stop stop that from occurring. Now, I'll talk to you about three sequential processes that leads to clotting. That first step in that sequence is platelet aggregation. And this is where a platelet plug is formed. All right, remember I told you that the platelets are traveling throughout the blood system individually, but when an injury occurs, then they become sticky, they begin to adhere to each other, and then they travel to that area where the injury is and form the clot. All right, so that platelet aggregation is the first step. And this is if you're trying to, in other circumstances, when you're trying to prevent the clotting cascade, this is what I was talking about when you take medications like aspirin or Plavix, those antiplatelet medications that will not allow this clumping, this stickiness, these platelets to clump together. But these patients also are at risk for bleeding. So keep that in mind too, because again, the platelet aggregation of this platelets clumping or stickiness that comes together, this is required before the clotting cascade, which has that multi-step process that we just looked at. All right. And so once the platelet plug forms at the injury site, then of course you have these chemicals that signals the blood clotting cascade to commence, right? And once it goes through a series of steps, what is the ultimate goal? The ultimate goal is the formation of a complete fibrin clot. Now, the platelets would be considered a clot, but it only lasts for a short duration of time, and that the platelets that forms that plug are pretty unstable. All right, they're not as strong, they're not as dense. But after the clotting cascade, these steps, when they lead to that fibrin clot, that is a clot that is much more stronger and that would last a whole lot longer. So keep that in mind as well. All right. So another way to view this, so you have this platelet aggregation or clumping that begins forming this platelet plug, again by platelets clumping together. And again, this is needed for the clotting process. And I also told you that normally your platelets are circulating in your vascular system as individual small cells that do not clump together until they're activated. So until an injury or something, some other reason, something occurs, they will continue to travel as small individual cells. After they are activated, these platelet membranes, they do become more sticky. And again, they lead to clumping, they clump together. And they form a kind of semi-solid plug in the blood vessels, that area that has been injured. All right, now this is very unstable, this particular clot, this platelet kind of clot, it's very unstable. What you need to really stop this bleeding is for the clotting cascade to occur. The only thing the platelets are actually doing is it disrupts blood flow locally to that area so you don't bleed to death. So it just causes a local disruption of blood flow to that area. All right. Now, some sources may refer to them as clots, but they're just not really strong, dense clots. But again, this clumping, this platelet clumping or somewhat clots, they just don't last very long. They last for a very short duration of time. And again, this only starts the process of hemostasis, this clotting process, in other words. All right. So whenever you check your patient's blood, their CBC, your CBC has your components, white blood cells, red blood cells, hemoglobin, hematocrit, has all these different types of white blood cells. Platelets are on your CBC as well. So when you obtain a CBC, a specimen from your patient, and you look at their platelets, if their platelets fall below a certain number, if they're too few in number, it can lead to bleeding. Because again, your platelets will start the clotting process first, though temporary, and this will eventually lead to the actual multi-step clotting cascade and eventually the fibrin clot formation. All right. So we said that the platelet plug, it actually starts this process. And again, this is what triggers the blood clotting to occur. So when you think about the blood clotting is a more amped up version of clotting. It just plays a much larger role in the clotting cascade when you think about those multi-steps that you saw in the video that I showed you. So just think about the clotting cascade as more amped up, on steroids, as we all say from time to time, as an example. Now, you also saw in the video where it talked about intrinsic factors as well as extrinsic factors. And these are different pathways that occurs due to certain things, such as, let's say, maybe trauma or something within. Well, trauma would be more or less external, but then there may be something within the person's body that may also bring about the intrinsic pathway, or the intrinsic factors. So when we talk about the intrinsic factor, it means that in order to trigger the platelets and to activate this blood clotting cascade, the patient has to have conditions like circulating debris that your book talks about, or venous stasis occurring within the blood. Now, you also have to remember that to continue the blood clotting cascade, there will have to be a requirement of adequate amounts of all the clotting factors and cofactors available. So without these clotting factors and the cofactors that is required for clotting, the patient would not clot very well. So all these components have to be available in order for successful clotting to occur. Now, when we talk about the extrinsic factor, just think about X meaning external, intrinsic meaning internal. Something is happening internally in the body, in the vascular system, that brings about this clotting cascade. But the extrinsic factor would be something outside, like an injury. So the extrinsic factor is outside the body, and factors that initiates platelets and clotting cascade, for example, trauma, when the blood vessel is damaged because of some kind of trauma. When the blood vessels are damaged, there's a portion of the blood vessel called collagen. And it is this collagen that when it becomes exposed, collagen is in the blood vessel walls, but when it becomes exposed, this is when the platelets are activated, and eventually the clotting cascade will come about as well. Now there are other blood vessel changes that can activate the platelets as well. For example, if a patient has inflammation, if there's some kind of bacterial toxins in the system, and also if there is some foreign protein. Because remember, the clotting system is also part of it does occur rather when this patient's immune system is activated as well. All right, so, even though we talk about the intrinsic factor and the extrinsic factor, both will eventually result in a fibrin clot and also localized blood clotting. Remember in the video where he showed you the intrinsic factor, he showed you all these steps, and then he jumped over here up to the upper left part of the screen, and he talked about the extrinsic factor, but that factor, the extrinsic factor starts, it's quicker. So it starts at another point in the clotting cascade, and then it eventually will begin to do the same thing as the intrinsic pathway. At some point, they've always start doing the same things. They'll go along that same pathway at some point. It's kind of like merging, or converging together, and then it'll eventually do the same thing. So, but not so much important, but just realize that they both will eventually lead to that pathway that will lead to fibrin formation, clot formation. We talked about now, there must be specific clotting factors. There has to be specific clotting factors. Calcium is required, and more platelets are needed to start this cascade of a platelet plug. And again, ultimately, this will lead to a fibrin clot. All right. Now, these clotting factors are actually inactive enzymes that become activated in a sequence. So that's like when I was explaining to you that, let's say if there's a 10-step process, they're inactive now, but in order for step two to be activated, there's an enzyme that must become activated to affect step two. And then for step three to be activated, something has to happen in step two in order to bring about step three. And so this is how they become more activated in this sequence. One event has to happen in the previous in order for the next step to occur until, again, we get to the fibrin clot itself. So at each step, the activated enzyme from the previous step activates the next enzyme. So maybe that'll make it a little easier to understand. So they depend on each other, essentially, right? Now, the last steps of the clotting cascade. So it talks about there's this activation of thrombin from prothrombin. In other words, you have prothrombin first, And then that enzyme is activated with prothrombin that will lead to thrombin. And these are the steps that are interrupted when you're thinking about some of these anticoagulants. It's stopping one of those processes. It may stop prothrombin from leading to thrombin and or it may stop thrombin from converting to or activating fibrinogen and so forth. So, and that's what I want you to be able to see, especially when you're looking at your medications, because it should tell you what step in that process is being impacted. All right. And so here we talk about activate thrombin from prothrombin, right? So again, from prothrombin to thrombin, and then there's a conversion by thrombin that leads to a change in the next step, which would be fibrinogen. All right. And fibrinogen will eventually lead to fibrin. And of course, the fibrin molecule is actually what forms the true clot, the strong and the sturdy clot. All right. Now, the fibrin clot formation is the last phase of blood clotting. All right. This, we talked about the fibrinogen being part of that step as well. Fibrinogen is an inactive protein that is made in the liver. So if you think about fibrinogen being that inactive protein made in the liver, if someone has liver failure, then they're not going to be able to clot. And so these patients can eventually bleed to death because, remember, the last step in that process is a fibrin clot formation. But if a patient's liver is compromised, maybe they're an alcoholic, maybe they have cirrhosis or maybe hepatitis, but at any rate, the liver is dysfunctional. And therefore, if they don't have the inactive protein fibrinogen, then fibrinogen will not be produced to where it will lead to the fibrin itself. So, and this is why I talk to you guys about understanding what each of your systems do. When you think about the functions of the liver, and the liver is what, again, carries that, it carries the protein fibrinogen. And so when the liver is compromised, then your fibrinogen is not going to be available to convert to the fibrin. And of course, without the fibrin, you don't have a clot. All right. So now, when we talk about the activated enzyme, which is thrombin, remember in that process, you have prothrombin, and then the next step is thrombin, and then thrombin is an activated enzyme that is needed to convert the fibrinogen into fibrin. And of course, if you give these patients a drug that directly affects the thrombin, then this thrombin cannot lead to fibrinogen. And again, without fibrinogen, you don't have a fibrin clot. All right. Now, but let's just say that if everything is working well, so the activated enzyme thrombin, it talks about it removes the end portion of fibrinogen. All right. So once it removes that end piece to your fibrinogen, this will convert to the active fibrin. All right. And see, we're steadily moving towards that fibrin clot still. And so linked together, so these are linked together to form the fibrin thread. All right. And the fibrin thread makes a mesh-like base to form a blood clot. So it kind of looks like a mesh type of base. And this is where or this fibrin mesh is actually formed. And this is where the clotting will begin to fill in those spaces and whatnot and form a much more stronger clot. And again, you all don't have to per se memorize all of this, but what is really more important is when we get to that piece where we talk about some of your medications and what it's actually impacting, then you'll understand why or how these medications are actually working. Now, when this mesh-like base is formed, the fibrin, well, let me just say the fibrin thread, it makes this mesh-like base to form a blood clot. Now, when the fibrin mesh is formed, then you have these clotting factor, or the clotting factor 8 is required in order to tighten that mesh. All right, and as this blood clotting mesh is tightened, it makes the mesh more dense and more stable. And at this point, more platelets can stick to the threads within the mesh itself. And it does have the ability to attract other blood cells and proteins, which again forms the blood cells and the proteins. And so again, this actually forms the clot itself. And as this clot tightens more, or we may also refer to it as retracting, as it retracts or as it tightens and becomes stronger, your book talks about how it squeezes out a kind of a syrup, a serum rather, and so this will complete the formation of the clot. So I know that's a lot, and as I said again, the only thing I want you to be able to understand is that it is a complex process. It is a long process, especially when we're talking about the intrinsic pathway. It is a very long pathway or process compared to the extrinsic. It's like if you think about the intrinsic pathway may start from 1 to 10, but when the extrinsic pathway comes in, it doesn't start at 1. It may come in at 5 to 10. So it kind of converges or merges into at a certain point in that cascade process, and then it will go along the same pathway in order to create the fibrin clot. So when you look at, do you all have this book right here? Y'all have that handy? This is your pharmacology book. If y'all can look on page 406, there's a table located there. So if y'all can get that for me, I think some people may have dropped off, or maybe not. All right. So if y'all can get that book for me, I'm just going to show you all something. So when you're doing your little research, hopefully you'll be able to see what I'm talking about. Yeah, that's good. Let me know when you all have it, because I want to show you all something real quickly. All right, so if you look at table 26.1, all right, look in the middle at the top where it says drug class as a header, and look at, it talks about heparins. And if you move back over to the left, it talks about prevent clot formation anticoagulant. And you see where it says inhibit clotting factors 2A, thrombin, and 10A? Y'all see that? So remember this clotting process. Remember, heparin is an well, first of all, we were talking about the blood clotting cascade. In other words, we're leading to a clot. In this particular case, we don't want a clot. Maybe the patient had a heart attack due to the fact that a clot blocked off the coronary artery. Maybe the patient had a stroke due to a DVT that became, which is a blood clot that traveled from the lower limbs to the brain. Maybe it traveled to the lungs, to the heart. So we're trying to prevent this clotting cascade from doing this thing, if you will. So as you can see here, remember all those numbers that you all saw, the numbers that I'm not saying that you necessarily have to memorize, but this will show you that it says inhibit clotting factors 2A, which is thrombin, and 10A. So it's just inhibiting or interrupting. And so it's kind of like if you can think about, remember we talked about the ROS system, and we talked about an ACE inhibitor or the the ARB and whatnot, which is an inhibitor as well. But essentially, in order to prevent the ROS system from occurring, somewhere in that process, it's going to inhibit it. All right, and the same thing is happening here. All right, where you are preventing that process, a process or a step in the clotting cascade from occurring. Does that make sense, everyone? Yeah, Miss Peggy, that makes sense to you? All right. Good. All right, look at the other one below that. That's warfarin or curcumin. So it inhibits vitamin K dependent clotting factors 2, 7, 9, and 10. So that is what that drug is doing. So it's inhibiting, and this is going to be important for you all to know because we're going to be talking about HIV, and we're going to be talking about, and we're not talking about this yet necessarily, but just to give you an idea or kind of a prelude to that conversation, AIDS goes through several steps before the cell is infected. So let's say if you have a 5-step process, and each step has to be successful. All the steps have to be successful in order for the host cell to become infected. And so we give these patients these medications, these AIDS patients medications that will interrupt that process along the way. So I'm trying to give you guys an idea that don't make pharmacology so difficult. It's pretty simple in what we're actually trying to accomplish. We're just trying to interrupt the process. All right. If I wanted to stop you from leaving your house and getting to school, what process do I need to interrupt to stop you from getting to the school? I'm gonna punch a hole in your tires. All right. I may put up a major detour somewhere where you're not able to, now I'm just trying to stop you from getting to school on time. Put up a major detour. I'll do something else. I don't know, maybe I'll throw a rock at your car or something or another. But my point is, I'm going to interrupt that process. I'm going to stop you from getting to school on time because I want you to get in trouble, Ms. Cameron. I want you to get in trouble. All right. So, and so essentially this is what is happening here. I want to inhibit something in that cascade process. And that is what I want you to understand. Now, look at the third one. These are direct thrombin inhibitors. Remember we talked about prothrombin and then thrombin, and then we talked about fibrinogen, and then from fibrinogen, it goes to fibrin. So in this particular case, it is a direct thrombin inhibitor. So if we can prevent the thrombin, will it travel or will it have its effect on fibrinogen? No, because we're what? We're inhibiting it. So this is, it says a mechanism of action, which is a short mechanism of action, inhibit thrombin or factor 2A. Isn't that simple? And look at some of the medications here. Argatroban, that was always a hard one for me to pronounce. Argatroban, Pradaxa, Angiomax, Thrombate, Reflutin, Argatroban, or I think it's Argatroban. There's an IV form of that too. I'm not sure if that comes in PO preparation. Well, look at the fourth one. It's a selective factor 10A inhibitor. And we know that 10A is a part of that cascade process. And so there's an inhibitor factor 10A. All right, and look at some of the medications. These are some of the medications that you guys should be familiar with. The Arextra, the Eliquis. I'm sure you guys have seen Eliquis on the commercials. Xarelto, y'all familiar with that one, right? So, and then some of the rest of these. All right. All right, now check this out. Look at the antiplatelet drugs. It interfere with platelet function. So they are aggregation inhibitors. So it will not allow the, remember these platelets are running around as individual cells until they're activated. What activates it? An injury. Then they come together, they stick together, and they travel to the site of injury, and they form a plug, stops you from bleeding. Localized bleeding, it stops it. And so in this particular case, for whatever reason, we may not want, we want to slow down the process, this clotting cascade. So what do? We give them things like Plavix, Prasugrel, there's Remodulin. So there's just a variety of Integralin. You'll see Integralin a lot when your patients have a heart cath. They come back, they have this Integralin drip going. And this is, again, to slow down that clotting process because you don't want your patients to develop clots. All right. Now look down at the next one. It talks about lysis, a preformed clot thrombolytics. Now let me tell you something about this. It's something you need to know. So when a patient develops a clot already, your anticoagulants, such as your heparins and what have you, they do not dissolve those clots that are already formed, right? They only prevent future clots from forming. All right. So these thrombolytics, they can dissolve a clot that is already formed. Your heparins, they cannot. They cannot break down a clot that is already formed. If someone has a large clot, let's say in their pulmonary vascular system, as in a pulmonary embolism, that clot these patients will be placed on heparin more than likely, unless they're allergic to it. But when that heparin is started, it would just prevent new clots from forming, but it will not do anything to that existing clot. And for that reason, you have to give these patients thrombolytics, and that will lyse. It will break down that clot. It says here, dissolve thrombi the clot, right? And this is in the drug class tissue plasminogen activators. This is something I believe is on your test as well. So you can use this table to help you to answer some of those questions. When you're talking about your mechanism of action and those drugs I sent you, I think I sent you heparin again for you to look at. Heparin we talked about in cardiac, but we're talking about it again with cellular regulation and these other blood disorders and whatnot. Now look at some of the drugs here. The tenecteplase, Caflo activase, alteplase. This Caflo, I think this is one of the ones if your patient's catheter is clotted off and you can't inject anything in it, you can't use it, they'll inject this to break up the clot so you can use the line again. So you don't have to put the patient through that again by inserting another line. That's why you always want to keep your lines flushed. After you flush it before, you administer the medication, and you flush it afterwards. Sometimes we as nurses, we get in a rush and we flush the line, we give the medication, and then we walk away. We don't do anything after that. And then the line gets clotted off, and then you can't use it again, and the nurse is coming on, or they can't use it. So we have to be considerate of our patients. Look here also, down here where it says reversal drugs. Remember I told you guys about those antidotes and things that you need to make sure you know. So if a patient is getting heparin and maybe you need to reverse it quickly because you may have to take them to surgery, emergency surgery, or maybe they're bleeding a lot now. Because with heparin, we look at the PTT. The normal PTT is roughly between 60 and 70. You got a patient who's at 200, and now they're spontaneously bleeding. You want to be able to reverse that, right? So look at protamine sulfate. Is what you're going to give this patient. Look at warfarin antagonists. They use vitamin K. This vitamin K helps to coagulate. Warfarin helps to anticoagulate. So they're opposite. Yeah, so those are the main two that I want you to be aware of. And so you can use your book to help you to build your database. I would try to do is hopefully as much as possible with this. I mean, we're here until 5 anyway. So what I'm going to do, now let me ask you all this. And let me just say that your grid can only be as effective and comprehensive as the persons who are actually working on them. Do you all want to work in a group on your grid? Or do you want to work individually on your grid? And let me just say before you answer that, one reason I would recommend working, I mean, you can do it either way if you want. One of the reasons I would recommend as an individual is because you're actually going through the process of looking up everything. But if you all want to divvy up the work and, hey, you work on this one, you work on this one, and then you create this grid and whatnot, and of course, you send it to one another for review. Hopefully, each one who is working on it, you're doing the work to where that the document is very informative. You don't want to do a work that is half done, if you will. And then your other cohorts, when they look at it, they're like, "What is this?" You know. So, what do you all want to do? You want to work together? You want to work in groups, separately?
I'd rather do mine cards.
So you prefer cards as opposed to the grid?
Mhm.
Well, if I am flexible. If that helps you guys to, the only thing, how are you going to show that your work was done?
I can take a picture.
Yeah, I mean, if you can take a picture and still upload it to the system, yeah, you all can do it that way too. Now also keep in mind, and hopefully, I don't know what your record keeping is like. Mine is not the best, not like it should be. So, if you just have a way of saving these cards so that as you move forward to various other courses, you know how to retrieve them. I don't want you to just make the cards just for this class, just for this test, but this is something that you're going to have to look at for quite a while. So, so that's the advantage of doing either a grid, preferably the grid, but if you don't feel like you can learn as effectively that way, then I certainly don't want to get in the way of how you actually learn. But if you look at the grid, it actually does show you what components we're looking for. So make sure you observe each component and have these on your cards. And a lot of people do cards, so I'm certainly not opposed to that. Anything that can help you guys to do this. I just want to give you the time to do it. I'm hoping that you'll be able to get through everything today, and that way it will give you a jump on tomorrow's, or give you a jump on what you have to do tonight or this evening when you begin to study. So you're kind of studying now as you're making these cards. Again, pharmacology is going to be it is a fairly sizable portion of your quiz. So make sure you do well. Make sure you understand these medications because you're going to be passing a lot of it, and you need to keep your patients safe. So I guess with quite a few of you who are wanting to do cards, is everyone pretty much doing cards?
I don't.
And who's that?
Take care.
Here. So, Ms. Jones, are you going to be working on yours alone or what?
I would like to team up with somebody if that's cool. But if you want us to do it alone, I'll do that too.
Well, we have, and of course, this is not nothing. Well, I guess what I'm trying to say is, we obviously have different learners who just prefers to do things a certain way. I don't know what your relationship is like with different ones in the class. So if you want to, I don't know, reach out to someone, I can go ahead. I already have the groups already set up. So those who want to be a part of that group, they can. And those who do not, you don't have to join. This may seem a little weird, but I have Project A and Project C. I don't have Project A and B. And it's because I couldn't add you all to Project B for some reason. I don't know why. So if you guys will go ahead and those of you who want to do the grid, you can log into, let's see, you should have received your invites. Let me look here for a minute. So in Project A, you have Miss Lynch, you have Miss Cameron, which I know she won't be there. I think Miss Emmerich decided to do cards, and I'm not sure about Miss Hollis, if you want to do cards or not. or the grid?
I'd rather do cards.
So you're doing cards. So it looks like Miss Lynch, it looks like you would be in a group by yourself. Of course, we can change that. And for C group, we have Miss Williams, Mr. Wolf, Miss Jones, and Miss Aura in this group. Miss Aura, how would you be doing yours?
By grid.
So you're doing the grid. Miss Jones is doing the grid. Mr. Wolf, how are you doing yours?
I prefer to do it in cards.
You doing cards?
Correct.
All right. So, and Miss Williams, what did you say?
I'm probably going to do the grid as well.
So in Group C, there is Miss Williams, Miss Jones, and Miss Aura. And let me go ahead and add. Let's see, where is it? I am going to add, if I can find it, Miss Lynch to this particular group. The Project C, Miss Lynch, I'm going to go ahead and send you an invite. And that way, if you guys want to divvy up, let me go ahead and open these up first. C is open. So let me explain to you all something real quickly here before I let you all get started. When I was in nursing school back in the day, a day before we actually had to present for clinical, we had to go to the site. We go there with our civilian clothes on with a lab jacket. We'll go in there, grab the patient's chart, and we'll go through it. And we're basically developing a care plan. We have to know what the medications were, what their history, their diagnosis. I mean, all the relevant information that was required to know for that patient, we had to know, because again, we had to build this this care plan. We obviously had to know what the medications were, what they were first, what they were for, side effects, any special considerations. I say nursing implications, but you can refer to it as nursing considerations or special considerations, whatever. So the part that we're focusing on today is, instead of focusing on an entire care plan, the only thing I want you all to do is take the time to focus on the medications. So it's still something that you would actually do in the clinical setting. You're just doing the medication, the pharmacological aspect of it. Does that make sense?
Mm-hmm.
Yeah. All right. Anyone object to this activity? You all would be crazy to object to this one, let me tell you. You all be real crazy. Don't shoot yourself in the foot. Anyway, so it's 8:46 now. Go ahead and take a break, come back at 9:10, 9:15. Come back at 9:15, and then you all can do your thing. Make sure you guys take a picture. Again, those of you who are doing cards, take a picture, upload it. I'm assuming you all know how to do that, young group. And those who are doing the grids, make sure you swap and upload those individually, and you'll have that for yourselves. Does anyone have anything else?
You want us to meet here with everything done at 9:15, or just take
no.
a break and then come back?
Take a break now, come back at 9:15. You'll go on your lunch at about 11:30, come back at about 1, and you'll continue to work on what you're doing. But ultimately, I want you to meet back at 4:15. So that gives you guys a lot of time to get these cards together, right? got your test tomorrow, so use this time wisely. That's what it's for. But again, I have to reemphasize, I need you to know these medications. I'm telling you, this is so important. I want you to keep your license. All right.
Mhm.
Thank you.
All right. So I will. You all can text me if you have any issues, and just in case I walk away from time to time.